This is my first slide. There's no picture because I'd like to start by relying on a very powerful alternative technology, words. Imagine, if you will, a young woman somewhere in Africa. She's on her way to a medical clinic, but she's very happy and excited. She thinks she's pregnant with her first child. She sees a doctor who confirms her good news, and then he asks her if she knows she has HIV. And whatever else the doctor can say after that, all she can hear is, I have AIDS, I'm going to die, my baby's going to die. In Africa each year, nearly 1.3 million babies are born to mothers with HIV/AIDS, and more than a third of the infants will have the virus themselves. Meanwhile, new drugs developed over the last decade have resulted in pediatric AIDS being virtually eliminated in the developed world. Looking at why, you saw a map of population dispersion. There's HIV prevalence. And there are doctors. Now, I could do the same thing with any other kind of health provider, you'd see the same thing. Health systems in the developing world were struggling to provide adequate care even before the AIDS epidemic, but now even that basic capability is compromised. But in spite of these odds, the drugs to prevent mother-to-child transmission have become available throughout Africa. They're remarkably simple to administer, cost-free, and very, very effective. But most of the women who could access this treatment simply don't. Frequently, less than 25%. And that's where Mothers to Mothers comes in. Now, why don't women access treatment when they can? Well, it's because meds don't equal medical care. The hurdles are psychosocial. Lack of information, fear of disclosure, stigma attached to HIV/AIDS, and the general disempowerment of women. So the health system, which is straining, just like me, can never catch up. Mothers to Mothers is our response to these seemingly intractable challenges. We're creating a new tier of professionalized caregivers drawn entirely from new mothers living with HIV. We hire, train, and employ them. That means paying them. Mentor mothers, as we call them, work in clinical settings, providing education, counseling, and support to their peers. They strengthen the basic services by shifting tasks away from the overburdened staff. And who could be more effective in overcoming barriers that prevent women from accessing treatment than someone just like her? Now empowered with knowledge, responsibility, independence. A professional, a resource, a role model, a source of hope. Words, women talking to another woman. That's the simple model at the core of what we do. It's inherently replicable and thus infinitely scalable, at least in theory, but moving from theory to practice is an entirely different thing. So from the start, we decided that we had to design a system which would apply private sector best practices to public health challenges. We put in place sophisticated infrastructure and management systems that would enhance our ability to scale, strategies allowing us to be consistent but remain adaptive, develop our management and reporting capacities, measurement systems, curriculum design, and training methods, while we kept the program itself focused to avoid mission creep. In only 5 years, the slide you saw before this showed our growth. We've gone from a simple program in the local townships around Cape Town to a multinational organization, 600 locations employing 700 women in 7, soon to be 10 countries all across Africa, delivering HIV services to over 200,000 clients every month. Working in these 7 countries, in the process of launching 3 more, we've got a simple model that we've shown can scale and adapt. And it seems like this was the easy part, because now we're on the radar. We have no shortage of opportunities to continue to scale, but now they come with strings. Change your delivery model. Add different services. Take on more, but save money. Why not use volunteers? Generally, adapt what you do to make it more like the way things have always been done. Going this route wouldn't be hard, since essentially it's in line with the public health status quo. Provide TA or training the existing health staff, do things the way they've been done before. Work within a system that structurally isn't working. And we don't exactly see how we add value in that context. More importantly, we fear that not only won't we recognize what our program will look like, but worse, it will come together in a way that is neither effective nor sustainable. We've always been working in a crisis, in a race against time. So we've always challenged ourselves to do more, better, faster. Change and adaptation are part of our DNA. And we know that what people are really asking us is how can we scale our impact to meet their particular needs? We think we can do this by adapting the roadmap that's worked for us so far, applying a private sector approach to a simple healthcare interaction. And we're developing a portfolio of models to respond to these new demands. This means trying something different in a sector where often, if something hasn't worked before, the response is, let's just try it again. But we'd rather continue to bring about improvement and change, and we think we have some answers. For instance, ways to adapt both our programs and our systems and implement them through affiliations that commit both us and our partners to working together for long-term results. But we're working in a system that isn't very amenable to change, and we all know that no matter what, change is hard, even when you share clear commitments and goals. Not surprisingly, our suggestions then are met with skepticism, anxiety, inertia. So my question to this group is, what's the best way for us, the new kids on the block, the upstarts essentially, to convince people to let us give a different approach in the healthcare sector a try? Thank you.